Good morning, gentlemen. I'll try not to call on you too much. The topic of this lecture is, of course, endophthalmitis, and I've actually pulled information from, I think, 4 books now. Of course, the uveitis book. Can you guys hear me? A thumbs up from Tamana? Yep. All right. Oh, good. Lots of people over there. Uveitis book, retina book, lens and cataract book, and the glaucoma book. There's actually some stuff in the orbit book. So anyway, this picture has nothing to do with endophthalmitis, hopefully, and I have no financial conflicts of interest that I know of outside of being a taxpayer, which does have some conflicts of interest, believe it or not, but probably not relevant to this topic. And I will discuss therapies that may or may not reflect their original FDA-approved indications. So, all right, gentlemen. Anybody want to tell me what endophthalmitis is? I'll just pick on people. Makes it easier to move along. Brent.
It's a inflammation of the vitreous, intersegment, other structures of the eye, generally related to infection, but it can be sterile.
Good. And you guys want to modify that in any way?
I like it.
Okay.
Involving multiple main chambers of the eye. I mean,
okay.
Yeah, it has to be multiple.
Okay, good. Multiple systems. We're not talking about just vitritis. We're not talking about just iritis. Now, what if the sclera or cornea is involved alongside? Does that change it at all? There's an antiquated term that's not defined in any of the books called panophthalmitis. Have you ever heard of that? So the main distinction, again, it's a little archaic, but there's nothing wrong with a little archaicism. Panophthalmitis means all of the layers of the eye are involved. So typically if you have sclera or cornea involved as well as intraocular infection, if you will, involving the anterior and posterior segments, then I would call it panophthalmitis. Here's a question for you. Can a virus cause endophthalmitis? Chris.
We're going to go for yes on this side.
All right. Josh Rowe. Okay, give me an example. I like having people participating from other campuses.
Herpes simplex.
Okay. Raise your hand if you've heard of herpes simplex endophthalmitis.
It's an educated guess, sir.
So here's what I'm getting at. So endophthalmitis is a really old term, and the book really doesn't nail it down a whole lot. But it does in the uveitis book say that it's attributable to a bacterial or fungal cause. And if you think about it, Josh Rowe is right. HSV, 1, 2, VZV, they all cause inflammation of the posterior and anterior segment simultaneously. In fact, you could potentially have a panophthalmitis due to that. But we don't use that term. And I've actually not been able to delve into why that is, except that perhaps it's always been related to this sort of history of us reserving it for fungal and bacterial causes. But I thought that was really interesting. I'm going to get back to this point at the end. But essentially, when we're referring to endophthalmitis, amongst friends here, we're talking about bacterial or fungal origin. And it's a little bit of you see it and then you get the context and then you say, okay, yeah, I think this is endophthalmitis. Whereas you could potentially see somebody with all the signs of endophthalmitis and maybe it's not due to bacteria or fungus. Now, do you have to have a hypopyon to call it endophthalmitis, Chris?
The ones I've seen have had a hypopyon.
Most of them do, but you could make a strong argument that if you get somebody post-op day 2 or 3 from cataract surgery and you catch them early, right, you might just see a lot of 4+ cell but no layering hypopyon yet. If you wait a little while, it'll become a hypopyon probably. So you don't have to have that for the clinical diagnosis. But can you tell me, Dan, what are some causes of hypopyon besides endophthalmitis?
Well, so you could have Behçet's.
Behçet's good.
So, or an ulcer.
Right. And you guys have any other ones you want to add? I've got a little list.
Refuge. Yeah.
Oh, that's not on my list. Good.
Retinoblastoma.
Yep. Good.
Yeah,
Good.
lymphoma.
Lymphoma. Good. All right. Good. So I think I put my mnemonic down before I went through them, but that's because I threw this slide together this morning. So contact lens too tight. I haven't seen this one yet, but it's one of those things I learned as a resident. By the way, this is a mnemonic I didn't make up, but I've used it a lot. Lens for lens-induced uveitis, retained lens material, IOL malposition, ulcer, endophthalmitis, the HIT HSV uveitis, iritis. This is not obviously comprehensive. So Lyme disease is kind of a weird one too, because I don't always think of that in the endophthalmitis category. But anyway, tumor, retinoblastoma, intraocular lymphoma, leukemia, so clue-hit. So let's kind of go through an interesting case here, since Tamana's already yawning.
Dr. Baskin?
Yes.
Are you recording this lecture, sir?
I am recording.
Okay.
Do you want to strike your name from the recording?
Negative, sir. I just have to head to the OR here in a little bit.
Okay, yeah, no, it should be available later on tonight. Okay, so this is a patient that we've seen. Raise your hand if you've seen this patient. Please don't say his name. Okay, good. Nobody's seen him here. So 22nd of January came over to Wilford Hall, and he'd had a painful eye for 2 weeks. His history, and he was not the best historian.
Oh, I've seen.
Okay, cataract surgery about a year ago. Yeah, I mean, it takes a little while to remember some of these people. So anyway, and so Ahmed valve, I think done at the same time. It's a little bit unclear in the history. And this outside hospital, he had a tap and inject performed, and then they referred the patient to us. He was taking a green top when he got to us. He'd had the tap and inject done 3 days earlier. Again, not the best historian. His vision's LP, and on ultrasound he had some mild vitreous opacities. Dilated fundus exam could not be done. Lots of gesticulation over at BMC. So, anybody, Dan, how would you describe this photo? And again, it's not the best, but it's better than anything we got in the photography section. I just took it myself with my phone. By the way, don't tell anybody I did that.
So obviously, very injected, 360 the conch is very red and upset. But the cornea looks more like he's got this. It doesn't look like. Well, maybe it is hypopian, but it might just be layered hyphema as well, or a combo that looks like it's a fibrin product. So maybe it is hypopian. So it's a little bit red, but the cornea temporarily looks like it's got more of an infiltrate and maybe actually even erosion or more like an ulcerated appearance.
Great. So, yeah, the photo's not the best, and that cornea is not actually focused, although it is a little bit divinous, so it makes it look more blurred than it is. He does have white blood cells and red blood cells in that layered hypopion/hyphema. He does have this big, infiltrate with overlying epi defect temporally. You could make a case that this is a corneal ulcer that went on to develop a reactive white blood cell hypopion. In other words, not necessarily bacteria inside of the eye, right? Although when you see mild vitreous opacities, again, it was a soft call. If you had definitive vitritis, you would say this is probably not just reaction, right? Something has invaded the eye. But if we didn't have that, we might just say, okay, maybe it's just an ulcer. LP is a little bit poor vision for that, but he's also got an Ahmed valve, so you want to go, all right, is this bleb-associated endophthalmitis? Why does he have a big ulcer? So we're going to come back to this guy. I'm going to give you a couple of answers and tell you what's been done so far. So let's talk about endophthalmitis and kind of begin to break it down into ways that we can manage it intellectually. So you could kind of break it down into just two broad categories, endogenous and exogenous. I kind of broke it down into three, endogenous, post-traumatic, and post-op. And then within endogenous, you can continue to break it down further, bacterial, fungal. Post-traumatic, this is not really a breakdown classification. These are the things I think about, Bacillus cereus, IOFBs. And then your post-op, you've got the acutes, you've got the delayed/chronics, and then you have bleb-associated. We'll talk about post-op first. Again, those three categories. And this is just kind of a brief rundown on each one. Acute onset, I meant to ask you guys, less than or equal to 6 weeks after surgery. Cons, coagulase negative staphylococcus, which is most commonly staph epidermidis, they don't always speciate, is going to be your most common cause here, roughly 70% depending on the study. Staphylococcus aureus, both of these can be methicillin resistant, right? and that's increasing. When I was a medical student, it's going up a lot. By the time you guys are in medical school, it's probably like this known entity. Yeah, if you have staph, it's going to be methicillin resistant. Streptococcus, mouth flora, right? Gram-negative organisms. Okay, delayed onset. Chris, sleep-deprived one. How soon can delayed onset occur, or chronic?
After 6 weeks.
Well, that would be the normal thing to say, and I think my slide says that.
After 6 or 10 weeks.
Yeah, so after 6 weeks is one easy way to define it, but really you could start to get delayed onset or chronic a week or two afterwards. And we don't talk about that a whole lot, but if you've got somebody with a little bit of inflammation that's coming in, that might be really early signs of this chronic. Because the other thing about chronic, and I'll get to this, is that they're indolent. They're really kind of slow moving. They're just happy to be there, and they're not going to really create a lot of waves. But P. acnes is the one you always want to think about, Propionibacterium acnes. Staph epidermidis, again, can have maybe a less virulent form. And then fungi can do this too, or funguses. So anyway, bleb-associated is months to years. You always have to think strep, Haemophilus, and then the gram-positives. So let's go on acute post-op. I wanted to kind of think of this lecture in a couple different ways. One is, what is it that you guys, as cataract surgeons, most of you, all of you, can do to reduce your chances of getting endophthalmitis? So, or at least to identify possible, risk factors. So diabetes, complicated or prolonged surgery, wound leak, vitreous loss, rupture posterior capsule. The 4 out of 5 of these are related to being a resident, at least early on. Your first case is you're at a higher chance of having a prolonged surgery, wound leak, vitreous loss, PC rupture. So, I mean, if endophthalmitis is going to happen, statistically speaking, it's going to be more likely to happen to a resident, even if it's just by virtue of the fact that you've got these extra things working against you. By the time you've done 10 or 12, probably most of these aren't an issue. And then obviously with supervision, I think really the only thing that affects you adversely as a resident here is your case. We let you, go longer than 15 minutes or 20 minutes, which is normal. You have to, learn how to do the procedure. And then the wound leak is addressed by sutures, right? Vitreous loss and rupture posterior capsule, there's not much you can do about that to prevent endophthalmitis. Some people will do intracamerals, right, antibiotics, or even oral. So antibiotic drops, everybody uses them. Nobody's actually proven that they're effective. And if you look at our data from I could have even broken endophthalmitis to post-injection endophthalmitis because of all the injections we do, hundreds of thousands now in the U.S. And we've shown that antibiotics don't help. In fact, they may actually predispose you to endophthalmitis. If you look at the reports that are out there, you're slightly higher risk of getting endophthalmitis if you do these post-op drops. I don't know if cataract surgeons are ready to take on a big study yet to prove that that's the same case for them, but certainly all I use is povidone iodine before. I don't even use it after I do the injection. In fact, if you're in my clinic with me, I take an eye wash bottle that's who knows how many cc's, we'll say 50 or 100, and I use that to rinse the eye out. And maybe I should use little BSS bottles and throw them away, but I mean, clearly that, the patients are doing well, and just with povidone iodine. So when I was a resident, this study came out, European Society of Cataract Refractive Surgeons. We've all heard about it now. Randomized study comparing topical levofloxacin with intracameral cefuroxime. The intracameral group was 5 times less likely to get endophthalmitis. Now, one of the big criticisms was, why in the world is their endophthalmitis rate so high in their topical drop group? And I haven't read the study in a while. I think it had something to do with when they started the drops or something, like some people wouldn't get them for a few days. Again, I have to look at that. Don't quote me. But it was higher than what we had, our published rates in the U.S. So a lot of people were slow to adopt this. But I think more and more people are taking on this intracameral antibiotics. And, I'm not going to dictate what happens with our cataract surgery since I'm not scrubbed in on most of them. But it is certainly worthwhile talking to folks. And you don't just have to use cefuroxime as the other thing. In the U.S., it's hard to get just a little bit of. You could even do Vigamox. So anyway, Vigamox has not been shown by ERG and animal models to have any adverse effects, even at full concentration. It's preservative-free, et cetera. Again, not really geared to go into that topic right now. So this is one of my favorite studies in the whole retina book, and it's mentioned in the uveitis book, and it's mentioned in some details that aren't mentioned in the retina book in the lens book. So I kind of pulled from all of them. So given this is my favorite study, if I remember to write questions for the test, I'm definitely including questions from the endophthalmitis vitrectomy study. So inclusion criteria, one, you had to have signs and symptoms of bacterial endophthalmitis, right? How soon after cataract surgery did you have to have your endophthalmitis to be included in this study, Dan?
2 weeks.
6. So 6 weeks. And could you have any other procedures besides cataract surgery to get included in the study? Tamana, she's shaking her head no. There's one other thing you could do to get included in the study, right? Secondary IOL placement. So you have cataract surgery, secondary IOL placement, you got included in the study. All right, what kind of vision could you have to get included in this study? Vincent Vu. And if you don't know, you could say don't know. Or you can make a really great guess. Could you be 20/20 and be included in this study?
No.
Okay, and what are some other parameters?
5% or worse.
Kind of the opposite, 20/50 to light perception. So if you're NLP, they wouldn't include you in the study. It's important when you think about these studies and you want to apply them to your patients, you've got to figure out whether your patient would have been included in the study to begin with or not. And that's a critical one. And then these next two I think are actually pretty interesting too. Cornea and AC clear enough to visualize some iris, but enough media opacity to obscure the view of second-order arterioles. That's like the best test question right there. Not a fill in the blank, of course, where you list off all 5. But I mean, who would have thought second-order arterioles, not even venules, arterioles. Anyway, they got to be obscure. Let me ask Brent a question. You got to speak up, Brent.
Yeah.
We just talked about testing people for light perception. I can give you a screenshot later, man. We talked about testing people for light perception. I told you my way. There is actually a way in this protocol for testing hand motion vision. Have I talked to you about this before?
Like a year ago.
Yeah, it's been a while. How do you test people for hand motion, and then we can critique your capability? Pretend like Chris is like kind of borderline hand motion / light perception, and just show me how you do it.
I try and cover one eye.
Okay, yeah. So let's assume you covered one eye.
In a bright room. So
A
that
bright
you can
room,
see
that's
the
good.
Difference in the shadows per se, and ultimately do like an initial wave and then wait and then try and
like a Hawaiian wave or like a Miss America wave.
I'm trying to remember back to the study.
So-
I thought
so-
it was a certain amount of.
Right. Okay. So yeah, Dan, you bring up a good point. When I was a fellow, I had heard that if somebody's hand motion, we wouldn't take them to the OR in the middle of the night, but if they're light perception, we would. So you would get somebody that would take a pen light, a Finoff, and put it right behind his hand and do this. So sorry, I should say what I'm doing. Light behind the hand and wave the hand. So you're getting this. You see the light, you don't see the light. So almost an LP test. So somebody who is LP would be able to say, I can see the light coming on and off, so therefore I must be able to see your hand moving, right? But in the protocol for this study, they actually want the light source, a well-lit room or a bright light behind the patient, so the light's projecting forward. And I think they did 5 times. I obviously am not going to quiz you on this too much. 5 times, and I do this with my patients. I move my hand side to side, and I say, which way is my hand moving, up and down or side to side? And they have to get it right. And then I move it up and down. I say, which way is it moving, up and down or side to side? And they have to get it right. And in this study, they had to do it 5 times. They had to get it right all 5 times. You think about it, I mean, that makes sense. You got to have some criteria for stuff. But it just helps you to understand that they actually had very rigid assessments of vision when it came down to these low visual assessments, right? Because they didn't want it, they really wanted to be meaningful to say some people with LP benefited, people with hand motions were just a wash,
Was there
right?
a distance?
Yes, there was, and I forgot what it
5
was.
feet or
It was like 5-ish feet, I think. There are a lot of exclusion criteria. If anyway, we won't go into it. If you're under 18, and my favorite two, unsuitability for surgery or a patient who won't follow up. And sometimes you can tell, sometimes you can't. Whatever. Okay. How do they break this study into groups? We'll ask Dr. Moses. Do you know? I'll tell you how many groups there were. Will that be helpful? And then can you tell me what each group is composed of? There were 4 groups. I'm seeing big smiles. That must mean you guys are so happy to be asked a question like this, right? Almost giggles. All right. 4 groups. Tell me one of the groups, or tell me the 2 big categories. What we talked? Yeah, that's right. You and I talked about AVS a long time ago.
Yeah.
She's like, listen.
There was a category that got a vitreous tap and inject.
Right. Exactly. And
there's And moving on to another category,
Yes. Let's say,
Okay.
go ahead.
there was a category that got vitrectomy with injection of antibiotics,
Great.
and there was a category
You got the main point of the study. They compared vitrectomy versus tap and inject, and with the vitrectomy they put the antibiotics as you mentioned. Then they took those big two groups and divided them into two more groups each with systemic antibiotics or no systemic antibiotics. In this case, IV or no IV. So then I made this little. I tried to come up with a good way to illustrate this. So yeah, they're joining together. So you get your 4 different permutations, right? All patients got intravitreal antibiotics. And I think it's important to know for testing purposes, but I personally don't think it's that important for the test that I put together. They all got Vanc 1 milligram per 0.1 cc, and they got, anybody know? Amikacin, right? The reason I don't test it is we don't do amikacin unless somebody's allergic. And so they got 0.4 milligrams per 0.1 cc. They all also got subconj antibiotics. They got Vanc and Ceftaz. They all got dexamethasone subconj, and they all got topical antibiotics, Vanc and amikacin. They all got oral steroids. Again, we don't do all that stuff. And then IV groups included ceftazidime and amikacin. Okay. So over on the left, you see a column, and this shows you the percentage. So there are 420 patients in this study, and I think 291 of them actually had cultures that came back positive, which came out to like 69, 70%, right? So 30% of these people did not grow cultures. Does that mean that they did not have a bacterial or fungal cause? I don't know what that means. That means that we didn't grow anything. That's all you could say definitively, but they had that clinical appearance of bacterial or fungal endophthalmitis, or hopefully bacterial, really, because that was the whole point. If they thought they had fungal, they wouldn't have included them. Not always easy to differentiate. All right, point is, at the breakdown of the ones that actually grew, most of them were cons, or staph epidermidis. And then you get about 10% each on streptococcus, mouth flora, and staph aureus, skin flora. 2% enterococcus, some hygiene issues there perhaps. Perhaps not though. And then gram negatives are 6%, other gram positives 3%. What do I think is important about this? Well, most of them are cons, coagulase negative staphylococcus. And then, so you could say 80% are staph to some degree. And a lot of those these days are going to be methicillin resistant. And also going along with that is fluoroquinolone resistance. So all you guys using Vigamox out there, and I know you've all done it. Don't look at me like you haven't. Just be careful because fluoroquinolone resistance is rising very rapidly as well. Okay, so this is interesting. So we're going to talk about this first category. The top part says HM vision. So that's if you came in presenting with hand motion or better vision. And then at the bottom, we're going to compare the VIT group versus the TAP group. And again, they both got intravitreal antibiotics. The difference is the VIT group got a vitrectomy, 3-port pars plana vitrectomy, and the TAP group just got an injection and then took a little vitreous sample, right? And for this study, they had to get a vitreous sample. Has anybody here tried to take a vitreous sample before? Raise your hand. Vincent, anybody there? Vitreous sample? No. Anybody in this room? Okay, so what I can tell you about it, it's like you get a milkshake that's mostly frozen and you put a straw in it and you're trying to get something out of it. It is really, really hard, okay? And so sometimes even with the old people that have more synoretic vitreous, you still can't get anything. Sunir Garg, one of my favorite mentors, he would say it's like you're going to the, what do they call the Asian drink with the little tapioca pearls in it? Somebody help me out here. The little balls in the bottom.
Vincent?
Bubble tea, thank you. You'd think I would be able to just roll that right off my tongue. Anyway, so bubble tea, picture trying to aspirate with a straw bubble tea, but then your straw's too small. It's like McDonald's size and not quite the full size. And then you get one of those little bubbles on the end of it and you can't get anything. So what I do, and again, I always do a 25 gauge needle. I don't do a 30 gauge needle. I don't do 27 because I used to go all the way down the line. Start with 30, then 27. You can imagine for the patient, it's just miserable. So then I'll go down, aspirate, and if I don't get anything, I don't just move the needle a little bit. Again, trying to stay away from other structures. I actually will redepress the plunger, and then move the needle and then pull back again. The idea is, again, you've got a bubble stuck on the end of your plunge, on the end of your needle, and you want to push it out, go reposition, and then aspirate again. And I'll try that a few times, and finally I'll just give up, and then I'll go to an AC paracentesis sample, which you can always get. Why do I prefer vitreous over aqueous?
They didn't get as much growth out of the
Right, your vitreous sample is going to be much higher yield. I can't tell you what the difference is. So for this study, did they have the option to go to aqueous? Yes or no for their sample on the TAP group? Vincent's smiling really big. I know he wants to answer this question. So in the EVS study or endophthalmitis vitrectomy study, were they allowed to take aqueous as their sample for culture? Yes or no?
I would say no.
You are correct. So what did they do when they had my problem where they couldn't get anything out?
Did they take them to the OR to do a vitrectomy?
I think Great. So I think they all had to be in the OR. I need to review the protocol. But they actually got out an automated vitrectomy instrument and took a sample. And can you tell me, Tamana, what percentage of patients ended up needing to go the way of the automated vitrector within the TAP group? I know it sounds obscure. So nobody will hold you to a percent.
60%.
Did you say 67%? You would be right.
Exactly.
So 2/3 of the TAP group got a vitrectomy of some sort. Now, again, they didn't get a complete vitrectomy. They didn't get even a core vitrectomy. They got a vitrectomy. They debulked some of the pus ball in the back of their eye. So that confounds the results a little bit. But anyway, so just keep that in the back of your mind. You can forget that, but it is a great detail and it's important to keep in mind when interpreting results. So people coming in with hand motion vision, how'd they do? Okay, well over 50% achieved better than 20/40 vision, better than equal to 20/40 vision, whether you're VIT or TAP. This is statistically not significant. Better than 2100, again, statistically not significant. So it didn't matter if you're VIT or TAP. Worse than 5/200, really bad vision, not significant. So hand motion or better vision, we already knew all this. Of course, I just broke it down a little bit more. It didn't matter which group you went with. Now, LP vision, we all know, is different, right? So if you wanted to get 20/40 vision, you better hope you're in the VIT group. You had a 3 times greater chance, 33 versus like 11% chance of getting 20/40 vision. Again, not a high likelihood that you're going to end up 20/40 or better if you present with LP vision. Better than 2100, you've got a double the chance if in the VIT group versus the TAP. And then better than 5 or worse than 5/200, TAP does worse. So if I were in the study, I'd really hope that I had gotten vitrectomy regardless of my incoming vision. You weren't worse off if you had better presenting vision, but you certainly were if you got in the TAP group with LP vision. Okay, now this is not minutia. You might think of it that way, but this is kind of fun for retina people. If you're diabetic and you had LP vision, you did much better with a vitrectomy just like everybody else. If you had better than hand motion vision, you did better with vitrectomy than the TAP group as well. So that's why you'll hear me ask on the phone if you ever, God forbid, have an endophthalmitis, is the patient diabetic? Because I'm much more likely to do a vitrectomy on them regardless of their presenting vision, if I can. Okay, so let's go on to this picture. These are from Trogshaw. The one on the left is 3 days after cataract extraction, probably not 20/20 anymore. The one on the right is 1 day later. Brent, what is this patient's prognosis according to the EVS study?
I would assume they're near light perception. So I mean, their visual prognosis? Or,
Yeah.
I mean, it's bad.
It's dismal.
Yeah.
I think this is actually kind of a trick question because this patient probably had LP, you're right, at best. This patient might have been NLP, I actually don't know. But the other thing is this patient wouldn't have been included in the study. They had this cataract surgery, they had the 6 weeks, it looks like a bacterial endophthalmitis. In fact, it ended up growing Streptococcus viridans. But their cornea is so opacified, there's no way you could see any iris, right? So that's an important thing to keep in mind. You can't tell this patient, you got to, if we do a vitrectomy, you got 1 in 3 chance of 20/40. This patient wouldn't have been included because, again, you couldn't safely do a vitrectomy, or you could do a tap and inject, of course, and that's probably what Chirag did. I didn't ask him on that either. But the point is that we excluded quite a few people from the study that had endophthalmitis just because we couldn't conduct the study effectively. So when you have the NLP patient, EVS is a nice way to start thinking about things, but it's not the end all be all. So I'm not going to spend as much time on these other topics because they're not nearly as interesting. Chronic post-op endophthalmitis. Again, we already talked about that. I didn't mention the recurrent, but it's indolent. It's going to be slow moving. Can be bacterial or fungal. Propionibacterium acnes is the main one you need to know about. And then you got other things like Staph epidermidis, Corynebacterium. Now, if this patient with P. acnes comes in, they're probably going to have pretty good vision, 20/50, 20/60. You see the peripheral white plaque, which I should have included a picture of, but didn't. And you're going to say, well, EVS says I should tap and inject. But the reality is tapping and injecting does not work for these guys, right? And there are different protocols that people go through. They might try something less invasive, but almost always you're going to start with a vitrectomy, capsulotomy. You're going to inject vanc into the capsular space. And then if that doesn't work, you're going to end up, at the end of the day, the most aggressive thing you can do is take out the lens, because think about it, hardware and infected eye, and then take out the capsular complex. So it kind of goes on a spectrum. It depends on how bad they present and who your retina person is. Okay, so chronic postoperative, I put this in here. I just made up this mnemonic. I don't know if it's worth remembering. But I commonly have people coming to me and saying, I have a patient with a little bit of cell. We taper them off of steroids. They're just not getting better. And so most of the time we just extend the taper, but you'll hear me and other folks say, okay, did you do gonio? Did you do a depressed exam? Did you look for any retained lens material? Is it a bad IOL position, right? You get some chafage. Is it uveitis, glaucoma, hyphema? I don't usually think about lymphoma in that context, but that is something to think about. Again, this is not a great mnemonic. It's like creme brulee, cells brulee. Anyway, cells after, anyway, you take it or leave it. I probably won't remember it tomorrow. So bleb-associated, we'll talk about briefly. The longer you make it after surgery, the more likely you are to get endophthalmitis, which is a terrible thing, but that's just the way it is. So 1.3% per patient year for superiors. The reason we don't do that many inferiors is 7.8%. Risk factors, there's a bunch. I won't quiz you. Well, anybody know any risk factors for bleb-associated endophthalmitis? Dan?
Shit.
All right.
Should know about it.
You're young and you're male, so you get 2 of them. Anybody else? What's another risk factor? There's certain things that you can, adjuvants that you use during trab surgery that make you more likely to get in. Right, and 5FU, good. So blepharitis, ocular trauma, NLDO, contact lens use, chronic blood leaks, all pretty intuitive, although the male and the young didn't, I guess you can make those intuitive if you wanted to be, and the anti-fibrosis agents. And then that's it for bleb-associated. I just threw that in this morning. All right, so post-traumatic, 2 to 7% of penetrating injuries. This is old data, and I don't think that's accurate anymore. If you look at our OEF, OIF, Operation Enduring Freedom, Operation Iraqi Freedom, those all early on, we didn't have any endophthalmitis cases, and we had well over, I think it was about 160 last time I kept track. We probably have some endophthalmitis at this point, but you take all of our open globes and our active duty population, we had 0 endophthalmitis early on. Marcus Collier and Dal Chun and Eric Weichel present a lot of data. None of them went to Afghanistan, but they got all the stuff coming in through Walter Reed. And basically, their hypothesis was that we were getting these people 4th generation fluoroquinolones or 3rd generation systemic right away, and we're doing primary closure right away. And that's probably the main reason. Some people argued, hey, you've got this really hot stuff going into the eyes, you got these explosions, and maybe that sterilizes it, but it's also dragging in skin flora, it may not really be sterilizing it, etc. So anyway, the point is that very low risk of endophthalmitis, and we used to think of IOFBs as being an independent risk factor, and you still should think of it that way for test-taking purposes, but it might just be the nature of the injury more than the IOFB that gets dragged in. The risk of endophthalmitis decreases with prompt wound closure and early removal of IOFBs. That's from the book, and I would agree with the first part. Early removal of IOFBs, we weren't removing them. That was the whole point of one of their papers. It was these people had the IOFBs retained in their eyes for days, weeks, sometimes months, and they weren't getting endophthalmitis. And again, if they'd had copper, right, they would have gotten that kind of endophthalmitis, but totally different. Chalcosis, your choice. And then, so I just highlighted the fact that I'll come back to this. Prophylactic antibiotics are recommended. This is a patient from Bill Benson. just a terrible case of post-traumatic endophthalmitis. I don't actually know what he grew out. We'll pretend like it's B serious, because this next slide is about B serious. This is a study from Iowa that showed, and this is in the book, 25% of post-traumatic endophthalmitis is caused by B serious. B serious is really bad. Soil-contaminated injuries, IOFBs. Again, in Iowa, they had lots of tractor and farm-related accidents, so you might be seeing a little bit of an observer bias or whatever, referral bias. Gram-negative bacteria commonly also seen. Excuse me. And then they said the role of prophylactic antibiotics is controversial, and this is literally listed on either side, or both these two pages that are right next to each other. So the reason I bring this up is that we don't really know. It is controversial if it's recommended. And also to remember that the BCSC is written over decades and is edited variably, and it's written by a committee. Did anybody see that movie? It wasn't very good, so I don't recommend it. The Giver. You guys are residents. Okay, Tamana's saying yeah. Anyway, Katie Holmes' character, it's Joey from Dawson's Creek. She was this mom, and anytime one of the kids, like the main protagonist, said something he wasn't supposed to say, like, I see color, everybody else seen black and white. She'd go, precision of language. And so this is kind of the same thing here. We don't have a precision of language. I don't really know why I brought this in. This is late at night. It's not sounding like a good idea anymore. And Becky and I always joke that we would start saying precision of language whenever our kids said something they weren't supposed to say. But, our BCSE does not have precision of language. It's written by multiple people, and there's contradictions. So it's not the Bible. Of course, Bible's, anyway, that's a different subject. So anyway, endophthalmitis post-traumatic. So anybody remember this from medical school? Be serious, Dr. Goofball, right? Anybody else read microbiology made ridiculously simple? That's like the only thing I remember from that book. Anyway, toxins are bad. And then there's also this picture of staphylococcus anyway. So intravitreal injection this is from the book. This is like the uveitis experimental section. Hemolysin BL toxin can cause direct necrosis of retinal cells, retinal detachment. As few as 100 of these bacteria are capable of causing complete loss of retinal function within 12 hours. That's why these things are so bad. And not only is it directly toxic, it stimulates the innate immune system. So then you get all of that sort of cascade of bad things happening. So that brings me to this study, which is by Ferenc, I don't know how to say his name, Kuhn, K-U-H-M. His first name is F-E-R-E-N-C. Anyway, he basically wrote this letter to the editor about after the EVS came out and said, listen, I'm doing vitrectomy on just about all my patients, and I'm getting awesome visual results. And I don't just do core vitrectomy or a little automated thing. I go in, do a complete vitrectomy. I lift off the vitreous gel. I almost just read his whole letter because it's really well worded. And then I clear out the back surface of the lens. I aspirate the front surface. I have to scrape off the epithelium of most of them. But he had like this 91% chance of 20/40 vision with vitrectomy versus you get 53% in the VS study. So they did a very limited core vitrectomy, even in their vitrectomy group, right? So they just said they kind of wanted to get 50% of the gel out. So they debulked it, but they didn't really get rid of it. But think about it. If you got all these toxins, if they're elaborating most of the damage, it's not the cells. I always picture them chomping away at the retinal nerve fiber layer, the ganglion cell layer. But if they're just releasing all these toxins and you sterilize it, you're not neutralizing the toxins. You're not putting an antitoxin, anti-venin in there or anything like that. So just something to think about.
Are you having increased risk of retinal tears and all that stuff in a situation where you're doing a real thorough vitrectomy?
Yeah, so he said that, he just said that he shaved the vitreous skirt. He didn't really just remove it. And I don't think he had any retinal detachments. I can't see the right side of the paper. He had a very low bad out complication rate. And actually the tap and inject group in the EVS study had 6 or 7% RDs, something like that. So, but it is something to think about. And the EVS did include folks with RDs to some degree. They kind of said on the ultrasound, if you see a choroidal or RD, if you think you could still safely do it, we'll include them. So endogenous, this is even less interesting to me, but we have to talk about it because it's in the book. Hematogenous dissemination doesn't account for many cases of endophthalmitis. Lots of risk factors, fairly intuitive. You got to look for possible sources: pneumonia, UTI, bacterial meningitis, liver abscess. Again, lots of different sources. I don't think these are worth committing to memory, except the last point says in Asia, Klebsiella from liver abscess is the most common cause of Endog. Anyway, and then the diagnosis, again, we've already talked about most of this stuff to some degree. You got to get your sample of fluid. You've got to do a gram stain, Giem stain if you suspect fungi. You want to do PCR if you can. Culture blood and urine or whatever that is that might give you a clue as to what's going on. And then you do your intravitreals intravenous sometimes. Again, doesn't really follow EVS, right, because it's endogenous. if you miss it, the patient could get septic, they could die, right? So you should keep that in the back of your mind. If something isn't adding up, could this patient have something else going on? Again, another phone photo. This is like first generation iPhone, so I'm lucky anything was even close to in focus. And this is after I did a tap and inject. This is years ago. Again, first generation iPhone had in like 2007 or something. But anyway, so you can see a little bit of blood at 6 o'clock below the pupillary border. But this patient actually had a dark hypopyon. And I changed my mnemonic just last night because I had Borrelia in the differential. I don't know where I got that from, but I couldn't find it in the literature, so I cut it out. So this mnemonic was blush, but now it's slush. So I took Serratia and put it at the top, and that's what this patient had, and that's a very common cause of nosocomial infections. Listeria monocytogenes, well-known cause of dark hypopyon, uveal melanoma, Streptococcus bovis. I just saw a case report. This is not one you need to memorize for a test, but when you see dark hypopyon, if you have this in your notes, you can look back at it and say, aha, I know what this is caused by. By the way, Serratia is used in the September 1950 Navy experiment in which it was dispersed. You weren't prior Navy, were you? No. Dispersed over the city of San Francisco to simulate what a biological attack could look like, and 10 people ended up hospitalized. 1 died with Serratia pneumonia. Anyway, secret government experiments, they're crazy. All right, so fungal, slow, focal or multifocal, most commonly, you should know this, Candida, and then Aspergillus is the second most common. Oh, what was I going to say? Oh, and it also begins as a chorioretinitis, breaks through into the vitreous. You can get iris nodules and rubiosis. So if you see iris nodules and rubiosis, you should think a little bit more towards the fungal causes rather than the bacterial, but that certainly is not exclusive. This is from Bill Benson. This is that string of pearls, sort of. They're not really in a string, but this is the best picture I could find of it. Wish I'd taken more pictures when I did see a lot of it. This is a little bit more common picture that I've seen where you get this kind of subretinal thing that breaks into the vitreous space. So when we get called to go rule out fungemia or fungal balls in the eye all the time, right? And that's totally legit because 9% of people that have a positive blood culture are going to have chorioretinitis due to Candida. So you should not only do it that first time, but also go back 2 weeks later and redo it because they could show up later. If you catch them when they're still chorioretinitis, before they get to endophthalmitis, the treatment can be tailored to them. And endophthalmitis, you can obviously treat them too, but earlier treatment has better visual prognosis. So in candidemic patients that aren't on antifungals, 37% will develop Candida endophthalmitis. That drops to 3% if they're on treatment. That's, again, a different study. Risk factors, all more or less intuitive, except that you don't get an increase in Candida-related eye infections in HIV patients. For the most part, they're case reports, but it's not like, oh, yeah, that you would have thought that, but that's just not the case. Less than 1 millimeter usually in diameter, have overlying vitritis, bilateral. Again, not a super overwhelming picture here. Those are not cotton wool spots. Those are actually candidal chorioretinitis. This is a patient that's 35 years old. Won't go into the details on him, but basically his GI dysmotility ended up with this Candida albicans. So again, I already mentioned that. See them, do it again 2 weeks later. I'm doing it with an ROP patient, or not ROP yet, pre-ROP patient in the NICU. I saw last week. I'm seeing him in 2 weeks, and I'll see him 2 weeks after that, or a week after that to start their ROP exams. So vitreous snowballs endophthalmitis requires diagnostic. I don't know if I agree with the diagnostic therapeutic vitrectomy if you already got Candida in the bloodstream, but anyway, it's something to think about. Vori is a great drug for the intravitreal injections. It's pretty expensive. It works orally as well. I usually do both if they can tolerate it. Aspergillus, all you need to know is second most common fungus. I went through and highlighted the stuff that's important because it's getting boring. And blah, 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 blah. They also get hemorrhages. Okay, most frequent fungal eye infection in patients with HIV/AIDS, Cryptococcus. All right, there's a picture of it. Not even in the book, or if it was, I don't like the pictures. And then you got coccidioides. We already know about this. Dimorphic soil fungus, Southwest U.S. Not common. Poor visual prognosis. There's a picture of it. I don't know. Oh, I never did that slide. Wasn't in the book. It was going to be bonus. Okay, let's go back to this guy as we're finishing up. So I said, okay, all the information I already gave you, and corrupted data. Nice. All the information I already gave you is what I was going off of. I said, okay, the TNI was done somewhere else. I don't know if we'll get the results. Let's go and do something more definitive. Let's just do a vitrectomy. Yeah, he's LP, but he's not. He doesn't fit the criteria for EVS, right? We had glaucoma look at him. Looked like his valve looked fine. There's no overlying purulent material over the implant. His tube wasn't extruding or anything like that. So I said, let's just do the whole deal. And then we got a call from the outside hospital. We called them, and turns out he's growing strep pneumo heavy growth just from his cornea. Nothing was growing from his aqueous or vitreous. This is like 3 days after the tap, and I haven't had any update on the results. Very sensitive to, what was it sensitive to? I wrote it down. Ceftriaxone, levofloxacin, and penicillin. So it was felt that, and oh, by the way, he had a broken suture right in this area where he has this gigantic ulcer. So hey, this is maybe reactive hypopyon, right? So we're going to, because there's no compliance, he's taking a green top, quote unquote, not his fortifieds that he was given. We decided to admit him. We admitted him over to BAMC, gave him around the clock, Q30 minutes for a while, fortified topicals, and had him follow up afterwards. He got a Procara while he was there because he's starting to thin out a little bit. Do I have another picture? This is from yesterday, so I don't have a photo from the 29th, but he was still taking a cefazolin, or cefalzolin. Anyway, Q2 hours, hand motion vision. He had this 1 millimeter mound of translucent fibrin hem inferiorly, but then he came back yesterday, 2 February, and now he's got this layered hypopyon that's a little bit bigger. It's about 1.5 millimeters. His vision's worse. He's saying he's tearing more. Cornea says he's got an early dysmetacele, whatever that means. Just playing. And, okay, and I did the ultrasound. I felt like he had even more vitreous opacities than he did before. Again, soft call, using a different platform. And again, I'm saying the same thing I said last time, which was let's take him to the OR and operate, because I'm still not comfortable with what's going on here, and I still don't know what category I'd even put him in. But he's not getting better. You could make a strong case that he's getting worse, and I just don't like it. He doesn't have an RD at this point. I think a 3-port pars plana vitrectomy has certainly it has risks, but given what he's been through, this is going on like a week and a half, 2 weeks. It's time to do something more definitive. So Cornea disagreed very politely, said, well, let's just observe. So I called the patient after hours and said, don't eat breakfast, and we'll see what we're going to do today. So we'll see. Today we'll find out. I want to show you this because this is really interesting. One of my friends, Senior Guard, who I mentioned earlier over at Wills, took 21 patients that had endophthalmitis, presumed bacterial, and did cultures on them, and he got about the same rate as the EVS, close to 70%. He also compared that to, so he had bacterial, fungal cultures, whatever, typical. Then he also had 16S quantitative PCR, so he had these 16S primers, right? I think the ribosomes, right? And so he basically had these pan-bacterial primers and basically found that the culture results that he got lined up with PCR culture, or PCR results, right? But then he did this other thing called deep DNA sequencing, which is like kind of finding everything that's got DNA and trying to figure out what it goes to. And he also did 7 controls from people that were getting like ERM peels and things like that. So 56% of these culture positive results also had this other thing growing in them, torquetinovirus. Who's heard of that? Raise your hand if you have. You automatically graduate from residency today. Torquetinovirus is growing, so that's weird. And then in 100% of these culture negative ones, they found torquetino. And then you might say, well, maybe torquetino is just out there. But then all of the control samples had no DNA from torquetino. What are the conclusions? He had like 4 options for conclusions. My thought is torquetino is potentially the sole cause of endophthalmitis in these culture negative. We have 30%. Routinely, you get 30% culture negative. Maybe it's the sole cause. Maybe it's like an adjuvant. It helps the bacteria that otherwise wouldn't have been strong enough to overpower something, so they're kind of working in cahoots. I don't know, but it's something you'll probably see more of in the next 5 to 10 years. And I don't know what the treatments are, and I forgot to read up on like torquetino. It was just discovered like 15 years ago in some hepatitis patient, transfusion hepatitis. And my protocol, okay, decide on tap and inject versus vitrectomy. I already went into how I decide that. I always give VANC. I think you need to know this VANC, 1 milligram per 0.1 cc, and ceftaz 2 or 2.25 per 0.1 cc. If you suspect fungal, get it started earlier. I'm not like cornea. I don't need to grow fungus out before I treat it. If I suspect it, I'll treat it and sort it out later. And then start hourly fortified topicals, plus or minus Vori again. Start your topical corticosteroids. Cycloplegics are important. We're going to get that other guy started. He wasn't started on him earlier, the one you saw the picture of. And systemic antibiotics, even though 4th generation fluoroquinolones resistance is going up a whole lot. Only like 15% of staff, aurea staff, epidermidis are sensitive now. And you got to follow closely. I'll put this lecture up pretty soon, assuming it records correctly. That's the youtube.com URL. And then I have some of this stuff up with some mnemonics up on that blog site. These are the references, blah, blah, blah. Any questions? Good.
I do.
Yes.
What was the in the EBS? Were they using similar like gauge for the vitrectomy?
It was all 20 gauge back then. So take down the conj, use you create a big sclerotomy. We used to have a lot higher incidence of sclerotomy-related retinal tears because, again, you've got all this vitreous that's going every time you go in and out. Now we have cannulas, and the vitreous tries to do that, but it's not nearly as prominent of an issue, so you don't get as much vitreous drag back into the cannula than out the cannula. The cannula really stops a lot of that. Or that's what we think happens because we don't see the sclerotomy-related breaks like we used to.
Well, now with better instrumentation and everything, do you feel like it's reasonable?
I think it's even safer.
That's what I'm saying. Like, I mean, if you had endophthalmitis and you
Get the pus out of my eyeball right now.
That's what I.
With a good surgeon. I don't want just some kind of ranger going out there and just doing it because he can. But if I'm 20, 30, 20, 40, and I think there's a chance I can run staph epidermidis, maybe I'll take my chances to tap and inject. I mean, what Ferenc Kuhn was doing, if I'm saying his name right, he'd do the tap and inject right away. He'd follow super close. And then if they're starting to tank a little bit, his first thing that he would do is the vitrectomy.
Do you I mean, given that there was an endophthalmitis recently, do you tell people that you would go ahead with or do you just say, these are the objective that we have from the EBS, it's old?
No. I tell the patients what I think is best for them. There's too much data and it's really old. And the other thing is if you don't do the tap, if you do the tap and inject, don't do the vitrectomy, they might end up with really bad floaters. We just did a floaterectomy last week for that, right? They could end up with really bad CME. And when I looked at her OCT, the one that I waited on that had the tap and inject done, she's got this kind of, her foveal contour is not quite normal. Her nerve fiber layer looks a little bit thin in a few areas. She's barely hitting 20/40 right now. So I kind of wish I'd gone in earlier. I talked to the comprehensive doc who was on call that weekend and I didn't make a strong enough case. And I hadn't read the Kuhn study yet either. And again, the patient was better than hand motion vision. So it's hard to make a case against tap and inject when you've got really good data. And she's gonna be one of the people who does really well. Whereas my patient, she had staph epidermidis. My patient with Enterococcus fecalis, we did everything as aggressive as possible, and we're still dealing with bare LP. So I didn't emphasize this because it's not in the book, but I think the bug dictates your prognosis. The EVS study says vision dictates, but I think it's vision plus bug equals your final prognosis, obviously, and then what you do about it. So, all right, thanks, guys.